So this morning I want to introduce Dr. Nate Stewart. He's going to be talking on hip impingement today. Dr. Stewart is an orthopedic surgeon at Chippewa Valley Orthopedics in sports medicine. He obtained his undergraduate degree in electrical engineering and biomedical engineering at the University of Minnesota. His research fellowship in biomechanics was completed at the University of Minnesota's Orthopedic Research Laboratory. He did his orthopedic training at Mayo Clinic in Rochester. He's had several publications related to reconstructive orthopedic surgery. His practice is focused on hip and knee pathology with a special interest in hip arthroscopy and resurfacing. So please welcome Dr. Stewart.
Thank you very much. I want to first thank my colleagues here for the opportunity to speak. I think this is a very exciting topic. It's not often in orthopedics that something new comes along. Some things that we've understood and worked on about the same way for the last 20, 30, 40 years. But this is really a concept that's developed and become better understood over the last 10 to 15 years. So we're going to talk about femoral acetabular impingement, and there was the introduction. Now to advance. Let's see if we have a... There we go. First, I'd like to thank my partners, Dr. Berg and Dr. Robert. Many of you may already know them. They run the sports program in our office, and this is Lynn and our athletic trainers. And every year I learn something new from the athletic trainers about hip pathology and medicine in general. In the talk today, we're going to go with an introduction to this concept. Some of you may have heard a lot about this and already know a lot about femoral acetabular impingement. We'll talk a little bit about the discovery of this, and many of you, if you've been in practice for 10 or 15 years, will have been involved in the time period in which this was really starting to be understood and developed, and you'll see how we came to understand that femoral acetabular impingement is a major cause of hip pathology. We'll go over the imaging and talk about how to define the deformity in terms of x-rays. We'll talk about making the diagnosis. We'll look at activities that produce impingement, and we'll talk about treatment, and then we'll have conclusions, and there'll be plenty of time for questions at the end. To put it simply, femoral acetabular impingement is when the femoral neck bumps up against the edge of the acetabulum. And I think if you're just learning about this for the first time, you should think about this much the way you think about impingement in the shoulder. Just like when the edge of the rotator cuff and the humerus bumps into the acromion, it's a very similar problem. And a variety of anatomic variations can lead to this problem and make it more common, but not everybody who has those anatomic variations is going to experience symptoms. So very much like the shoulder. I haven't been around long enough to remember when we really didn't understand this at all. So this modern concept is really in the last 15 years where we started to understand it, and certainly the first few papers on the subject went highly unnoticed. Nobody really paid a lot of attention in 1991 when a surgeon named Reinhold Gans from Germany wrote the landmark paper describing this problem. Two different groups of orthopedic surgeons were looking at patients with hip pathology and kind of came to the understanding of femoral acetabular impingement from two different directions. One group you'd probably be most familiar with, was the sports doctors looking at patients who had labral tears, tears of the cartilage inside their hip. The other group was a group of orthopedic surgeons looking at patients who needed hip replacements at a relatively young age. What was happening is patients who were participating in high-demand sports would come in with groin pain. They might be diagnosed with a muscle pull, sports hernia, something like this, but eventually, with an MRI, an exam, they were diagnosed as having a labral tear. This was somewhat confusing to the sports doctors at the time. If you know, the labrum in the shoulder is attached to the capsule, so if you subluxate your shoulder, you can tear the labrum in the shoulder, but the labrum in the hip really isn't attached to the capsule. So they didn't understand at first how these labral tears were occurring. How is force being applied to the labrum in such a way to cause it to tear? So they were trying to understand that. A lot of early sports arthroscopists in the hip thought that perhaps the hip was subluxating out of joint, just like in the shoulder, and somehow that was rubbing in the edge. It turned out not to be the case. They also noticed if they took out the labrum, frequently the symptoms didn't go away, or they weren't improved sufficiently, or if they sewed the labrum back down, those patients didn't do well. The labrum retore, or they continued to have symptoms. So that's the sports orthopedic surgeons who are seeing these patients. This is an arthroscopy photo. Many of you have seen an arthroscopy photo before. As you know, the arthroscopy is like a periscope. You don't see the whole joint at one time. You just kind of see a little bit of it at a time. I'm going to give you an orientation here. This is the edge of the femoral head, and the femur has been pulled out of socket there. There's the bony acetabulum, or the bony side of the cup. And if you follow along, that's the articular cartilage on the bone, but right here is the labrum. So this structure going along there is the labrum. And usually when a labral tear occurs, almost always it occurs at the junction between the bony acetabulum and the labrum there. You can see the tearing here. We've made a small cut in the capsule, and we have a probe that's pulling on the labrum, kind of finding out where it's torn. You can see this red edge here where the labrum has been bumped up against by the femur. And so this is what a torn labrum looks like at the time of arthroscopy. And so they were seeing those torn labrum in high-demand athletes. The hip reconstructive surgeons had a different problem. And I can remember specifically as a resident male when I had a patient coming in their early 40s who needed bilateral hip replacements. And he said, how come I need to have both of my hips replaced? And you have osteoarthritis, it's kind of wear and tear and, wears out over time. Well, the rest of my joints haven't worn out. And I milk 60 cows, my neighbor milks 60 cows, and he's fine, and both of my hips are shot. And we really didn't have an answer for him at that time. We didn't understand why his hips had worn out at an early age, and somebody doing the same amount of work, same sort of activities, didn't need their hips replaced. And that was a question that Reinhold Gans was trying to answer. Here's an example of a patient who needs a hip replacement at a fairly young age. This is a 43-year-old patient of mine, and these x-rays don't project extremely well. In fact, they don't project that great. But if you look on the right side, if we could see, there's a little space left, and many of you have seen arthritic x-rays before. On the left side here, it's hard to see, but you have bone-on-bone arthritis. This is a 43-year-old computer operator. It's hard to tell him that it's wear and tear and that he's just done too much, and at 43 he should have his hips replaced. By carefully examining the anatomy of these two different groups of patients, the surgeons from these different perspectives came to understand that what was happening was the femoral neck was abutting against the edge of the acetabulum and causing undue force at a small portion of the hip, causing it to wear out early in some cases, and in the other cases causing the labral tears that we see in the high-demand athletes. And what they were seeing is that people who are in their teens and 20s were coming in with hip pain, with labral tears. Patients with the same deformities in their 30s, 40s, and 50s were coming in and needing a hip replacement. The basic concept of the two bones bumping together can be divided into two types of deformities primarily, though most patients have a little combination of both. And we'll talk about these. The first, if you read about this online or in your educational literature, you're going to hear about CAM type. This is the most common type. It's much more common in men than in women, and it's probably the easiest to see on x-ray. The other type is the pincer type. Basically, that's when the acetabular edge is too far forward or the acetabulum is too deep. And then a third cause of impingement, not really published about much, but when we go to our hip meetings, they talk about this some, and it's kind of a difficult patient. It's the patient with hyperlumbar lordosis. And so the whole pelvis is tilted forward, bringing the front of the acetabulum down, butting against the femoral neck. Here's an x-ray of the CAM type of deformity of the hip. So what you can see, if you look at the x-ray on your left, this would be read as a normal x-ray. Here's a person with good joint space. They don't have an unduly shallow socket. They don't have dysplasia of that nature. This looks fairly normal. But if you look at the lateral x-ray here, so this is with their, the femur's down here, here's the acetabulum. This is with their hip flexed up. So this is the anterior edge of the femur, and this is the posterior edge of the femur. And if you look at the posterior edge for a moment, you can see how when the leg is put back down, or straightened back out, there's going to be plenty of room for the acetabulum to roll back into here to this notch in the femur. There's room for the acetabulum and the femur to be next to each other. But if you look at the anterior edge, right at the edge of the ball, it's just straight and flat. And you can see as you bend that hip up, that flat edge is going to butt against the acetabulum, at much less flexion than a normal hip. That's probably a key concept. Does everybody kind of see that more or less? I don't know if you can see it from across the room as well, but flat edge, not enough room for the acetabulum to rotate into that space. That's the CAM type of deformity. And we'll look at the same deformity, but look at it arthroscopically here. This is, to orient you here, this is the head of the femur. So the acetabulum would be up here somewhere. The neck is down here, the leg would be down here. Basically, you have most of the hip looking just fine, plenty of normal acetabular cartilage, a nice normal ball, but at that edge, you see there's a lot of impingement taking place. There's fraying, there's damage to the area of the CAM lesion on the femur, and on that same patient, if you look over on the acetabulum, you're going to see damage to the labrum and the edge of the acetabulum. So that's an arthroscopic photo of a CAM impingement. It's nice to start with CAM because that's pretty easy to see. I think the pincer type is a little harder to see on X-ray, but basically the idea with the pincer type of deformity, the edge of the cup or the edge of the acetabulum is just too far forward. So they don't have to bend up too far before they bump into the edge of the acetabulum. This X-ray here, especially with the projection you have, you could not really see it very well. But what we do is you need to concentrate on the posterior line versus the anterior line. In the posterior line, you go up the ischium, follow the posterior line. That's the posterior wall of the acetabulum. You come around, you follow the anterior wall. To make it easier, we put in blue and red. They're not like that on the normal X-ray. But here's blue for the posterior wall, red for the anterior wall. In a normal cup, that blue line should be further lateral and the red line should be further medial. What happens in a person with pincer deformity is that line comes across this way, and so radiographically we call this the crossover sign. In other words, one of these edges crosses over the other. That doesn't normally happen unless they have the pincer deformity. So this would be a crossover sign with the pincer type deformity, the edge of the acetabulum being too far anterior. This is what it looks like looking at the crossover deformity at the time of arthroscopy. What you're going to see on your left side is, again, the ball here, the acetabular head, excuse me, the femoral head. There's the acetabulum over here. And it's hard to appreciate in this because it's not projecting perfectly well, but here's the labrum, and it really hasn't completely detached yet, but it's blistered away from the bone underneath. So here's the labrum, and instead of having that cartilage firmly attached to the bone, when we push on it with a probe, it's like a layer of sod or something that's come up off the ground. It's just not attached on a carpet that's wrinkled up off the ground, to imagine it that way. And this is just how you'd imagine it would tear as it's bumping there. It's like hitting a door stopper over and over again, and eventually the rubber just gives at the base, and it's coming detached at the base. To show you where that is on the X-ray, on the right hand of the slide, you see we're doing the arthroscopy. That's actually the arthroscopy instrument with the camera looking in. This is that probe, that's that probe. And we're probing on that torn area, and we can see it's exactly where the crossover takes place. It's where that anterior edge of the cup is too far forward. That's where it's bumping, and that's where the cartilage is becoming detached. So it correlates very well. The pathology on the X-ray and the pathology we see at the time of the scope. This last one's a little bit harder to see on X-ray. It's something called hyperlumbar lordosis, and I think athletic trainers and physical therapists are very attuned to the patient's body habitus and how it affects how they participate in sports. But basically, it's people who have a very pronounced lordosis in their back, a real sway to their back. When that happens, their pelvis is tilted forward, and it can take a fairly normal cup and rotate that forward so that they don't have to flex their hip up as much to bump into the edge of that cup. And the X-ray would show, if you're used to looking at these X-rays, you'd see that this is kind of like too big an open mouth, because instead of being a true normal AP, they've rotated. It's almost coming what we used to call the outlet view of the hip. Give me the outlet view. Here's, I think it's easier to see on this slide. This is a diagram of a person with hyperlumbar lordosis. Basically, as that spine comes into more lordosis compared to the normal, they just rotate that pelvis forward. The edge of the cup comes more forward. So a third, less commonly discussed cause for impingement. This part, I think, is the most important part. If you only remember one part about this talk, it's how to make the diagnosis, because there's a lot of patients you're going to see, a lot of athletes you're going to see, you are probably going to know more about femoral acetabular impingement than their primary care doctor or lots of other people that they may see. So in many cases, you'll be able to make the diagnosis and be the first person to make the diagnosis for this patient. So how do we make the diagnosis? There's the history, the physical exam. At that point, you have to cooperate with the physician for imaging. We'll talk about that, though. And then we'll talk about the differential injection, which helps confirm the diagnosis. Just a caveat, of course, athletic trainers know more about groin pain than lots of, even doctors, right? Lots of people pull hamstring muscles and groin muscles and stuff, but these patients are going to come in with a slightly different time course to their injury. It's going to be more chronic, it's going to be more repetitive, it's not going to be as dramatic, it's not like all of a sudden it came on. And so you'll be able to, hopefully be able to tell it from the groin pulls and stuff just by the history, but that gives you a hint. They'll be participating in activities that have a lot of hip flexion and internal rotation. That's when those two bones bump into one another. They'll have groin pain, less commonly trochanteric pain or gluteal pain, but it can radiate into the trochanteric region, the side of your hip, or into the gluteal region. If you ask them where it is, they usually give you the C sign, and we'll show you what that is. If they've had enough impingement that they've actually detached that labrum, they'll complain a lot of popping and catching. But they can have femoral acetabular impingement. If they haven't torn their labrum, they may not have any popping and catching yet, but they can still have groin pain and symptoms without having torn the labrum. Just like a patient can have pain from impingement in the shoulder without having yet torn the rotator cuff. This is the C sign. This is where if you ask them where it hurts, they'll, all your patients will be nice and thin because they're athletes, but they'll grab around their hip and they'll say, it really hurts deep inside here. And it's not just here or here, but just kind of right in there. And they can describe it as a deep pain. Now, this, I think, is another really important part of making the diagnosis. You should be able to learn from these videos how to do this test and see if people have the impingement. Now, you have to remember, just like the shoulder, not everybody who has impingement is that causing their pain, but you'll be able to tell if their bones just don't have enough range of motion in them. You'll be able to tell if they can't bend very far before the two bones bump together. So with this video, we're going to start with a normal person getting the hip impingement test. And then we'll go show somebody with impingement. And you'll be able to see the difference pretty clearly. So here we go with the normal test. And the normal test, you flex the hip and the knee to 90 degrees, keep it in neutral abduction, adduction, and you externally rotate the leg. So you should be able to externally rotate. About 35, 45 degrees is kind of the edge of normal. You see this person, we can easily externally rotate that much. And it has a very soft feel. You get to the end, and you can tell you're kind of stretching tendons at that point. It's not like a bony end point when you get to the end of a normal person's hip range of motion. So that's a person with a normal hip impingement test. Now this person has an abnormal test. I picked some of the distinctly abnormal tests so it'd be easy to see. In addition to the lack of motion, if we're trying to see if the impingement is causing their symptoms, they should experience some pain at the end of the range of motion. So what you do, flex it up, do the test, and say, does that reproduce your groin pain? Is that how it hurts when you're playing sports? So here's the abnormal test. Again, flex up to 90 degrees, don't allow it to abduct or adduct, and that's all his hip turns out. It doesn't turn out. And he doesn't have any symptoms on this side, incidentally. He had symptoms on his other side, and we'd already fixed his other side, but I needed somebody to make a video. So we showed his asymptomatic, but his hip just doesn't turn in, and it impinges with that motion there. Now, if he wants to flex his hips up, he's learned over the years to keep his knees a little bit apart, externally rotate his legs a little bit, and he can squat down and pick things up. But if he brings his legs together, it bumps pretty easily. That's probably a key point. Is there anything about that want to clarify at all? Or that's probably the thing. If you want to take home one practical thing from this talk, learn how to take your kids, your athletes, and set them up and do that test and see how much motion they have. Not a super hard test. If you learn that, you'll be able to put that on your list of things to do for a person with hip region pain when you're examining them. X-ray and CT imaging is used to define the bony anatomy. And we just talked about how the bony anatomy is what produces the lack of motion in the impingement. The MRI helps us look at the labrum, which is the cartilaginous rim of the cup, and look for some other possible causes of pain in the hip region. So the MRI not only helps us to find people with femoral acetabular impingement, but it helps us rule out other possible causes of hip pain that would be treated considerably different. So this is a 3D CT, and I think for people who are going to be doing surgery and femoral acetabular impingement, this is now the gold standard for how we look at the two bones together. We look at how the edge of the acetabulum sits, how the femur looks, and it allows us to kind of see it in all dimensions. And at the time of surgery or in the office, we can rotate it around. We can look at the bone from several different angles and look for the bump on the femur and see where that corresponds to the bump on the acetabulum. So in terms of body anatomy, I think that's the best study. Not always necessary to make the diagnosis, but helps a lot. Here's an MRI showing a labral tear. I hope this projects pretty well. Here's their femur. There's the ball of the femur, the acetabulum. And here's the capsule, and it comes up. It's really not attached. It's just right next to it on this MRI. But there's the labrum. And that labrum should be continuous with the bony acetabulum, but that cleft there is where the labrum is torn away from the bony acetabulum. So it always tears away from the base of the bone. And you can see a labral tear on MRI. This is an MRI of somebody who has something called avascular necrosis. So this is a type of pathology that would cause groin pain. It might hurt when you're doing the impingement test. And they'd have a lot of pain, but you can see the top of the femur, actually they have it on both sides. The top of the femur here has died for lack of circulation. Over here they have a crack through part of the bone that is dying. So it rules out avascular necrosis as a cause of hip pain. That patient might have a very normal x-ray and a very abnormal MRI if they have avascular necrosis. The other one, and this is particularly important for people involved in treating athletes, this didn't project great, but again, the femoral shaft, head of the femur, a femoral neck stress fracture. Actually, just by history, you should be able to kind of differentiate the stress fracture from a labral tear. And stress fractures have that distinct pain pattern. Every time they put weight on it, it hurts, like ouch, 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 ouch. If you ask patients about their pain, they'll be able to say, every time my heel strikes the ground after I go a certain distance, then it's ouch, ouch, ouch. But it's nice to know, especially if you're thinking about surgery, rule out a femoral neck stress fracture. This is one of my patients who's a 35-year-old runner. And then the history is, right, it's different if you have a young girl playing volleyball having hip pain versus somebody who's a distance runner. The differential diagnosis shifts in terms of what's more likely. I can imagine a scenario where you're taking care of your athletes at your school, they're having hip pain, and you're wondering, do they have femoral acetabular impingement? So you send a note back to their primary care doctor and say, this person might have femoral acetabular impingement, please get an x-ray of their hip. You need to be very cautious about the normal hip x-ray, and for a couple of reasons. One, FAI is a new concept, and really I would say, well, the first paper was in 1991. It wasn't like in all of our orthopedic and radiology lecture series until the last 5 years. It wasn't really out there. So a radiologist may not be familiar with that diagnosis. Certainly the family practice doctors are not going to necessarily have had the training in it. They may, but they may not. And the other aspect, so they may not know what they're looking for, not have thought to look for it. The other is it's like hooking the acromion. If you take a shoulder x-ray and the radiologist doesn't have a specific goal in mind, they're going to say, no fracture, no arthritis, and that may be the end of it. You need to mention, the doctor who's ordering the x-ray needs to mention that you're really looking for impingement in the hooking of the acromion for it to be mentioned in the shoulder x-ray. Same thing for the hip x-ray. If someone's going to request a hip x-ray, they better say, does this patient have a pincer lesion or a cam lesion, so that you can trust that a normal x-ray really means a normal hip.